then you can start. Yeah. Good to go.
Hi, everyone. I'm Salman. I'm a previous ultrasound fellow at Royal London, currently doing my PRU fellowship at Royal London, and I'm also an ST5 trainee with KSS, currently on an OOP. So as we all know, we're all enthusiasts in PoCUS over here, and I'm also a PoCUS enthusiast. I'm just going to talk today about the concept of extended examination with ultrasound. And my talk is going to focus on abdominal examination with ultrasound. So these are my credentials. This is a presentation that I prepared for the conference, so I'm just copying the same presentation. If you have any questions in the meanwhile, just put it in the chat or put a hand up or ask the questions, and we'll try to answer your questions. Okay, a second. It's stalled. There you go. So yeah, just to let you know, I'm not an expert in this field. I just have a little bit of experience, and I might say things that might be controversial. But yeah, I think PoCUS is all about controversy at the moment. So let's see how it goes. Right, so the objectives for today's talk is what is extended examination with ultrasound? And why should we be doing extended examination with ultrasound, and how does it benefit our patients? And an approach to an acute abdomen, which is my approach to an acute abdomen with ultrasound. Okay, so everybody would talk about why not just PoCUS, or how extended examination with ultrasound is slightly different from PoCUS. So PoCUS is basically an ultrasound examination to give you an answer to a particular question, which could either be yes or no or indeterminate. So you can either be looking for a pneumothorax, so just do a particular scan, a focus scan, just looking for a pneumothorax, or you can be looking for pericardial effusion, and it will be just a focus examination just to rule in or rule out pericardial effusion. So ultrasound, however, is so extended examination with ultrasound is slightly different because it involves a full examination of a body system with ultrasound, with the help of ultrasound. So I consider a full wavelength for use of ultrasound. So I think PoCUS comes at the very beginning, where when you start learning doing ultrasound examinations and you start doing focus examinations to look at different pathologies, that's where PoCUS comes from. And on the other spectrum is a full examination by the radiologist or radiographer. And in between the two, I think if you get more experience, you can do an extended examination with an ultrasound. So this is where the controversy might come up, that how would you govern it and how, give me a second, sorry, let me just admit everyone. Yeah, so this is where the controversy would come up, that how would you govern it and what's your experience and how do you credential things? And at the moment, it's quite difficult to get certification for a full body, full organ system examination. I think there is some credentialing system for lung. Heart, obviously, echo has a credentialing system based on BSc level 1 and level 2 echoes. But with the rest of the body systems, it's quite difficult to get yourself credentialed, and especially for abdomen, because radiology doesn't cover all of the abdomen, especially the bowel. So why should we do extended examination with ultrasound? Because we can look into the whole body system. Sorry guys, my son is just at the back. All right. So you can look inside the body rather than just doing an inspection, palpation, percussion, or auscultation. Why not just look into the body system and look at the organs themselves and see where the pathology lies? So with an extended examination with ultrasound, you can basically diagnose most of these conditions. And I have myself diagnosed quite a few of those conditions. However, I just want to give you a word of caution that this is just an exam. I use now ultrasound as an examination tool, so it's not a definitive test. And if you still have a high pretest probability for a condition, then you should go for a definitive diagnostic test, which could either be a CT scan or a departmental ultrasound. So it doesn't replace your definitive diagnostic test. It's just a tool to enhance your examination technique. So, but why should we be using ultrasound to examine abdomen? Why not just use the age-old way of inspection, palpation, percussion, and auscultation? So I'm just going to give you a few references from the literature. So from a very common presentation, cholecystitis. We all go back with the clinical diagnosis. We clinically diagnose cholecystitis with Murphy's sign, and this is only 62% sensitive. However, with ultrasound, your sensitivity can go up to 86%. So again, the more sensitive your examination, the better it is for the patient. And especially in places where you are limited with resources, it's quite a game changer that you can do a PoCUS examination or extended examination in ultrasound. Appendicitis, again, history and physical examination. This is how we have been diagnosing or putting appendicitis as a differential diagnosis for most of our cases. However, if you do an ultrasound and if you find a swollen appendix, inflamed appendix on an ultrasound, the likelihood ratio is quite high. But again, if you don't find it, then you can't rule it out just based on your extended examination with ultrasound. So you'll have to go for a definitive diagnostic. Yes. Okay. Sorry, guys. All right, again, small bowel obstruction, physical examination, again, not sensitive at all. A lot of people do abdominal x-rays, and I particularly hate doing those because they're only 50 to 60% sensitive, and especially they're only mostly sensitive if the patient can stand up. If the patient is lying supine, the sensitivity goes down. So ultrasound, on the other hand, is quite sensitive to rule in a small bowel obstruction. So again, I think it's a no-brainer for people to use ultrasound for examining their patient, especially abdomen, where you cannot look at the organ systems themselves, and it's quite difficult to just based on your physical examination to say, like, this is the problem. So what extended examination with ultrasound of any body system it does, it allows you to increase the yield of your examination. And it also decreases the time to intervention. It decreases delaying investigations in some cases. And it also gives you a chance to do cognitive offloading. So if you're in emergency medicine, you've got like 4 or 5 patients on the go. And if you're waiting for some kind of investigative test to come out and to wait for the report, and it takes quite a lot of mental work to follow these patients up. So if you do an extended examination, you go into the cubicle, you do your examination, and you come up with the diagnosis. It just allows you to do mental offloading. So what I think how examination in future would be, it would be inspection, palpation, maybe percussion. I'm not a big fan of percussion. Auscultation, yes, it does still have a role, especially for chest and cardiac examination. But I think the next thing would be sonoscopy. So you should be using, or people would be using, ultrasound to examine their patients. So coming on to abdominal examination, so we're just going to talk a little bit about the scanning technique. So we would be using a curvilinear probe, which is a low frequency probe, so it allows penetration of ultrasound deeper into the tissues. And because abdomen is a deep cavity, you can look into the body's organs inside the abdomen. So there are different techniques for each of the organ systems. And again, this is where the limitation of PoCUS or extended examination with ultrasound would be, because we're not able to do all of the maneuvers or all of the positions. it will be difficult for us to rule out any diagnosis. So you can rule in, you can say, yeah, we found something, that's fine, but you cannot rule out because you cannot do a full system examination. So as you can look, there are different approaches. For liver and kidney, you would start from the midline with the pointer facing towards the head, and then start moving medially, as you can see, and then you would go in between the rib spaces. And again, you can then ask the patient to lie in the lateral decubitus position, and that can give you, that allows you to diagnose gallstones if they're moving inside the gallbladder. And again, for looking at the kidneys, again, you will have to lie the patient at the lateral decubitus position, looking at the kidneys from the back as well. So I'm just showing you this technique to to give you an idea that you might not be able to rule out diagnosis based on our examination, because most of the patients in the emergency department might not be able to do all of these maneuvers. Yeah, again, gallbladder, pancreas, starting from the midline, moving towards the lateral side, it will be gallbladder, and coming down in the midline, you would look for the pancreas that way. AAA scanning, again, midline. In an axial view, you can start midline and start scanning downwards up into the umbilicus. And for bowel, you can do a lawnmower technique, or I sometimes do a rainbow technique where I'll start from here and then go around, come back down, go around, come back down, and go around like that. Different techniques for examining your patients, but again, just to give you an idea that this is just a rule-in technique, not a rule-out technique. Any questions so far?
Yeah, nothing in the chat so far, Salman.
All right, so we're gonna talk about a few cases where ultrasound helped with patient's management. Either it changed the diagnosis or it expedited the patient's definitive care. So I've got a patient, I had a patient, 32-year-old female, came with syncope. After her syncopal episode, she was lying on the bed. Her heart rate was 66, blood pressure completely normal, respiratory rate normal, and SATs were completely normal as well. So I think probably everybody would know what the diagnosis is. Nope. Okay. Yeah, so
It's ectopic.
yeah, it's ectopic and respiratory, isn't it? Syncope. However, let's looking at the patient. If you look at the patient's heart rate, it's not very high. And again, it could be either that the patient is completely clapped out, or the patient is, okay, that's fine. Sorry about that, guys. Or either the patient hasn't bled quite a bit. Right? This was, so I did a scan for the patient. So if you look at the left upper window, you can see the right upper right upper quadrant window, and you can see free fluid in the Martian's pouch. And again, now you can see the left upper quadrant window, you can see fluid over there as well, and this is in the pelvis. And you can see the fluid also over here. You can see the fetal sac. And I think a lot of people want to do urine HCG on patients who come in with this patient because we need to diagnose pregnancy. And it's quite difficult because if the patient is in shock, then the kidneys might not be producing a lot of urine and they might not urinate. So getting this view, getting a embryonic sac view in the pelvic pelvis allows you to diagnose the patient with a pregnancy, and this is a ruptured ectopic pregnancy, unless proven otherwise. So this allowed us to diagnose this patient rapidly and move the patients to theater, and also start resuscitating the patient whilst the patient was being ready for theater. So FOS scan, or FAF scan, as it's called these days, I would say it's quite sensitive to rule out massive intraperitoneal fluid. People say that we don't use FOS scan to rule out anything, but I can say if the patient is in shock and you do a FOS scan and it's absolutely negative, then it means that there is no intraperitoneal fluid. The patient might have a retroperitoneal bleed, but you can't rule out a massive intraperitoneal bleed. Also, what I use mostly my FOS scans for is in code red patients or young female patients presenting with collapse, because that's where the most utility of these scans is. Second case, 96-year-old male, fall from stairs. Again, looking at the patient's heart rate, well within range. Blood pressure is slightly low, and he's got a left upper quadrant mass. Any ideas what this might be?
Jay says splenic rupture.
Yeah, so yeah, I mean, that was one of the differentials, left upper quadrant mass, but this is what we found out on the scan. I hope this plays out. So what we're looking at over here is, this is abdominal aorta, and this patient already had an EVAR to correct the AAA. From that EVAR, the patient had a bleeding, and this is a pseudoaneurysm over here. And what happened was, this was the pseudoaneurysm, which was the left upper quadrant mass that we can see on examination. And when the patient fell, this pseudoaneurysm burst, and the patient then bled into the peritoneum. But when the patient arrived, he was hypotensive, in shock, but still alive at that time. So this allowed us to diagnose what was going on with the patient rapidly. Based on these findings, we still went for a CT scan, obviously. But looking at these findings, this allowed the vascular surgeon to come up with a management plan. So we were able to tell the patient what was going on quite quickly, and the patient's son as well. And they were able to make a decision that they didn't want to do anything, and they just wanted to die peacefully. So again, in this case, PoCUS, or extended examination with ultrasound, allowed us to expedite the patient's management, make the patient comfortable, and give us a diagnosis quite quickly for that patient. Okay, so I would say AAA scans are one of the most useful scans in ED, because these are scans which will give you information about life-threatening conditions. And I think most of the people have their diagnosis of AAAs when they come to ED. And if you are in a DGH where you don't have vascular surgery, then it's very critical that you do a AAA scan of the patients coming with back pain or abdominal pain, an old male or female, and you can expedite their treatment and ask the ambulance service to take them to the scan place where they have vascular surgery. So this is my approach to patients who are in shock. Although I do a full shock scan, but this is my approach to their abdomen. So I would do a FOS scan to rule out a massive hypoperitoneum. Now I'll do a AAA scan to either rule in or rule out AAA. And also, whilst doing that, I will look for any signs of perforation. But again, I'm not ruling out perforation, I'm just ruling in if I can find any signs of perforation. And if not, then I will be looking at liver gallbladder and kidneys for any signs of infection, which could be either cholecystitis, liver abscesses, or hydronephrosis due to obstruction history. Any questions so far?
No, it's great, Salman.
So, coming on to the third case, this was my friend who was a 35-year-old. He's a rugby player, and he comes to the ED whilst I'm in ED, my last shift in one of my older hospitals, and he comes in with 2 days of vomiting and abdomen pain. So he walked to the recess, vitally stable, looks a bit off, but he just comes in and said, look, this is what's going on. I don't know what's going on. Can you have a look at me? So I look at the patient. He's got some signs of abdominal tenderness, but it's not peritonitic. And I do next day examination with ultrasound, and this is what we find. So what you see over here, guys, is our loops of small bowel. And as you can see that there is quite a lot of fluid and hyperechoic shadows in the loops. Usually you cannot see the small bowel loops this distended. Usually they are very small and you cannot see clear fluid in them. But if you see anechoic fluid in them with hyperechoic shadows and they are distended, then it's likely that the patient has small bowel obstruction. And again, this is another view. And also you can see that in between those bowel loops, there is anechoic free fluid. So just within 5 to 10 minutes, I was able to diagnose this patient with small bowel obstruction and perforation. Funny enough, he had some morphine and the surgeon came, the consultant surgeon came, and he looked at the abdomen and he said, no, it's not a peritonitic abdomen. Why don't you do a CT scan? Obviously, we requested a CT scan early anyway. The radiologist missed perforation in the CT scan reporting. However, I was quite adamant that the patient has got perforation based on these findings. And when the patient had surgery, the patient had about 7 liters of free fluid in his abdomen. So again, in this case, it allowed me to get to a diagnosis very quickly. And in some cases where physical examination was limiting even for a surgeon, consultant surgeon, this allowed me to advocate for my patient and to get the definitive diagnosis for our CT scan. And when the radiologist missed the findings, and again, this scan helped me to again advocate for my patient and move to theaters quickly. So the patient was taken to theaters within 4 hours and he had massive intraperitoneal fluid and small bowel obstruction.
That's a great case, Salman. There's a question from the chat from Justin, just about in terms of the free fluid, how can you tell it's from perforated bowel and not ascites or like just reactive fluid?
Again, this is based on pre-test probability and patient's history. So the patient is a young person. He doesn't have any liver problems because I knew the patient personally. So I knew that he didn't have any liver problems, anything like that. And you don't have free fluid in the peritoneum unless either you got ascites because of liver problems, which you didn't have, or you got some kind of infective process going on, or perforation. And it's unlikely to have an infective process going on within like a couple of days or so. So it's either blood or perforation from small bowel obstruction.
Cheers, man. I appreciate the explanation.
Okay. Again, yeah, this is like, as I said, it's slightly different how radiology or radiography is doing because we got a good advantage because we got the patient in front of us, we got the history in front of us, and then we can do a slightly extended examination in ultrasound and get more information. So again, all of this helps because if you get if you send the patient to radiologist, not most of the times we don't put the right history when we ask for a certain examination. So the radiologists don't know what they're looking for. They just report whatever is in front of them, and they might miss a few things if you don't ask a particular question. So again, if you're doing the scans yourself, it's helpful because you know what you're looking for, or you got certain differentials in your mind that you really don't rule out. Okay, so a few tips about small bowel obstruction. This is one of the scans that I love because there's been so many times that I've had fights with radiologists for not going for abdominal X-ray and going for a CT scan because I said, look, I've diagnosed the patient with a problem. Just tell me where the problem is, where the obstruction is. So yeah, not the bowel wall thickness, sorry, it's bowel wall dilation. So in between the two bowel walls, that if the distance is more than 2.5 centimeters, it's likely that the patient has got small bowel obstruction. However, if the difference, if distance is more than 3 centimeters, it's more than 90% sensitive for small bowel obstruction. A few other signs are altered peristalsis, as you can see in the last patient. There is to and fro movement of bowel contents, but there is no good peristalsis, which is moving fluid content or content inside the bowel forwards. It's just to and fro movements. And it's also sometimes called to and fro movement as well, because fluid is there. Bowel wall thickness greater than 4 millimeters is not a very sensitive indicator, but it could be a sign of ischemia. If the bowel wall is boggy more than 4 millimeters, then there is possibility that the patient might have ischemic bowel rather than just bowel obstruction. And what you're seeing over there is ileus because of ischemic bowel. Free fluid as well, again, can point towards infective etiology or perforation. And what it does, it just decreases the time to intervention, whether it's a definitive diagnostic investigation or patient needs to go for surgery. Okay, coming on to case 4, 78-year-old female treated for septic shock, drowsy, hypotensive despite 3 liters of fluid and worsening AKI. Any idea what's going on? Okay, so for me, extended examination with ultrasound helps a lot in patients who've got dementia or older or frail patients, because they might not be able to pinpoint what their problem is. And if you examine their abdomen, they might be tender all over, or they might not be tender at all. They might not elicit tenderness. So for me, it's very helpful because I can then look into the abdomen and find out what the problem is or where the problem lies. So this patient was given 3 liters of fluid, the lactate was worsening, and the AKI wasn't getting better. The patient wasn't producing any urine and was getting more and more hypertensive. Okay, so although I borrowed these slides from the PoCUS atlas, but this is something what I found similar to what I found on the patient scan. So this is the right kidney. And does anyone have an idea what you're looking at?
Hydronephrosis.
Yep, lovely. And this is the left kidney. And again, a little bit of hydronephrosis. So if you see this kind of finding in both the kidneys, if both kidneys have got some degree of hydronephrosis, it's very important to look at the bladder as well. So this was the bladder. So what's going on over here on the right side, this is severe hydronephrosis. So as you can see that there is cortical thinning and you can't see the papillae, the kidney structure is lost and there is massive dilation of the pelvis. Over here, this is mild hydronephrosis as the structure hasn't been lost. And what you see over here is a mass inside the bladder, which is obstructing the ureters. So the patient had some kind of a bladder mass, most likely carcinoma and that was obstructing both the ureters, and the patient also had pyelonephritis. So what this patient needed was not more fluids, or patient needed a nephrostomy. So this scan allowed us to expedite the patient's treatment, and the patient then had a nephrostomy within like 4-6 hours. However, the patient died later on because of multi-organ failure. But again, it just gave us an idea what was going on with the patient rather than treating them blindly and not knowing what we're treating. Okay, so just to talk a little bit about grading of hydronephrosis. I don't think it's a very good picture, but again, yes. Mild dilatation of the pelvis, of the kidney, but without loss of structure of the papillae is mild hydronephrosis. And if you start losing the structure of the papillae, then this is moderate. And if you lose complete structure of the kidney with cortical thinning, then this is severe hydronephrosis. And again, I do the scans quite often in my patients who come with renal colic, and this can help us if you find hydronephrosis. First of all, you have your diagnosis. Secondly, then the patient needs to have a CT scan because we need to find out where the obstruction is because it's causing kidney. Okay, coming on to the 5th case. I hope you're not getting bored. A 70-year-old female male, 3 days of inability to pass urine, abdominal pain, and swelling. And the handover was given by the LES crew was that the patient has urinary retention. So I sent one of my SHOs to see the patient, and last time he was a junior SHO. He just came to me and said, I don't know what's going on with this patient. Why don't you come and have him? So scan the kidney, and this is what we, so right upper quadrant, this is what we find. Can anybody find out where the pathology is, or do you have any guess? Chat. Could be dissecting abdominal aorta. Yes, but the answer is in these windows. So if you look at the kidney, there's something wrong with the kidney. Okay, so just to give you a bit of explanation. So you can see there is a bit of anechoic shadowing above the kidney in the Marsden's pouch. There's some free fluid over there. And if you look at the kidney, it's not very homogeneous. It's got some heterogeneous shadows. So there's a shadow, hypoechoic shadow over here. There's a hypoechoic shadow over here, and it's not a cyst. It's not a simple cyst. It's got septations inside it as well. And there is some degree of hydronephrosis as well. Okay, so we do the left upper quadrant. Again, similar kind of a picture. You can see that there are some shadows in the kidney. It's not a very homogeneous cortex of the kidney. Okay. So this is the bladder. Anybody guess what this is?
Looks like the Foley catheter balloon.
Yeah, there's a Foley catheter balloon. And the patient had a catheter which wasn't draining. So by doing the scan, we could find out why the patient catheter wasn't draining, because patient's got a lot of debris inside the bladder, which is probably obstructing the catheter. So this patient had this catheter removed, put a new catheter in, which drained about 500-600 mils of fluid, and again, stopped draining again. Again, scan the bladder. There's a lot of debris over there. Okay, so coming on, doing further scanning of the abdomen of the patient. And I think everybody can guess what this is. So,
Awesome.
Didn't catch that. Okay, so this is again dilated small bowel loop, and what you can see over here is to and fro motion of the fluid inside the bowel without any effective peristalsis. You can see the valvulae conniventes, which are the small loops inside the small bowel. And this is called the piano sign or the keyboard sign, because you can see that these are like the keyboards, the keys of the keyboard. Again, this is a sign of another patient with small bowel obstruction. However, as you can see that the small bowel wall is quite thick, more than 4 millimeters. I didn't measure it, but you can see that it's quite thick. So what happened was with this patient, I said that this patient has got multiple kidney abscesses along with small bowel obstruction and some kind of enteritis. So all this radiologists up, they wanted to do an X-ray first. After some persuasion, we got this CT scan. And again, lo and behold, we found out multiple kidney abscesses with hydronephrosis, small bowel obstruction, and source abscess. So because of the scan, it took us about 4 hours, 5 hours to get the scan, even in a trauma center, because our scanners were down. But we were able to start the treatment early. We were able to start the antibiotics, put the NG in, start flushing the Foley catheter. So the treatment was expedited because of our scanning, rather than waiting for a radiologist to do their scan and then report on the scan. Again, this is another case. This is my last case, guys. I'm not gonna bore you more. So 18-year-old sickler, fever for 1 day, not complaining of any abdominal pain at all. However, when I examined his abdomen, it felt a little bit peritonitic to me, but he wasn't complaining of any abdominal symptoms at all, just fever, and that's it. And this is what we found on his scan. Sorry. Okay, so if you look over here, so this is the liver, this is the gallbladder. Not a very good view, but as you can see over here, the gallbladder wall are thick. There is some pericholecystic fluid around the gallbladder. Although we cannot see any stones in this view, but there were some stones as well, because he's a sickler, likely to get stones at an early age.
I didn't know there's stones.
Yes. Okay, so this patient who wasn't complaining of any abdominal symptoms was diagnosed with a cholecystitis, and that was the reason for his temperature and infection. So again, if you have a difficult patient or a patient are not very clear of their symptoms, especially elderly or young patients, children, extended examination with ultrasound does help. It gives you an idea about what's going on, and you can look into the body and look into the pathology yourself. Okay, so this is my approach to an undifferentiated abdominal pain, which is stable, who's not really sick or in shock. The right upper quadrant, look for liver pathologies, liver abscesses, most likely, any free fluid, hydronephrosis, and then scanning for cholecystitis. Also, you can do a VEXA scan if you are aware of that. So you can do venous examination with ultrasound, looking for signs of congestion. Left upper quadrant, again, looking for any splenic pathologies, any splenic abscesses, free fluid and hydronephrosis. Coming to midline, looking for small bowel obstruction, AAAs, pancreatitis, all perforation, as you can see. Left lower quadrant, right lower quadrant, appendicitis, ovarian cyst, and again, similarly on the left lower quadrant. Okay, in summary, as I said, if you want to increase the yield of your examination, you want to come to a conclusion earlier, you can incorporate ultrasound for your examination of any of the body system, especially abdomen. It does reduce time to intervention in quite a few cases. As you can see, I've summarized 5-6 cases for you. It can assist in early diagnosis of the reason for the shock in your shock patients. However, just to tell you again, it doesn't replace the confirmatory diagnostic test. Okay, so if the patient needs a CT scan for a diagnosis of small bowel obstruction or bowel ischemia, they should have their CT scan. So these are the references from all of my stats that I've produced. Thank you. Any questions? Let me know.
Thanks, Salman. That was fantastic. Really beautiful images you had there. Yeah, if you guys want to perhaps turn your videos on and say hello and any questions, that'd be amazing.
Hi, I was just thinking, you've shown some lovely small bowel obstruction. Is there any way that you can diagnose large bowel problems?
So large bowel, there are some studies, although I'm not very good at large bowel, but you can diagnose diverticulitis. There is some literature around colitis as well. So some people have diagnosed pseudomembranous colitis and also Crohn's disease. But apart from that, I don't know anything about large bowel. You cannot, in my opinion, you cannot diagnose large bowel obstruction on ultrasound because the problem with large bowel is that it's full of air. So you cannot look into the organ itself, the large bowel.
Yeah, okay,
Yeah.
that's helpful. Thank you.
Yeah, I agree. I guess if you've got a really distended abdomen and you scan it and you only see gas, or you don't see any fluid-filled bowel loops or ascites, then you'd be quite suspicious that it's a large bowel because it's probably either going to be a volvulus or something that's creating gas-filled bowel loops. But yeah, you can't sort of directly see it like you can with the small bowel. Any other questions?
Any questions?
Comments?
Okay.
Yeah, that was good, Salman. I really liked the beginning. You were talking about like the spectrum from the very focused binary scan to the comprehensive scan. Obviously, comprehensive scan isn't really suitable for our sort of our pace of work, like measuring every single structure. But I think, yeah, there is definitely a role for a more extended scan, as you say. I think once you've been introduced to how easy it is to scan things like gallbladders and kidneys, while you're there scanning the aorta, it just makes no sense not to look at those things if they're relevant for your patient.
I think it's just quite useful because it can increase your pretest probability. But again, a negative examination, just as we examine patients when we do clinical examination, a negative examination doesn't mean that the patient doesn't have a pathology. So you can then move towards a definitive diagnostic technique. But if you find, so you can say, look, clinically, I found the Murphy sign, you can still say that clinically you found an examination on cholecystitis.
Yeah, and I think a lot of studies compare point of care ultrasound to conventional ultrasound or to CT or other diagnostic modalities, whereas if you think of it more as an extension of your examination, maybe a more fair comparison is to compare clinical examination without PoCUS to clinical examination with PoCUS. And I'm sure if that study was done, it would show that it definitely enhances your overall clinical assessment.
So now the medical students are being taught ultrasound. Yeah, hopefully in the next 5 years, 6 years, people will be examining with ultrasound.
Yeah. Well, thanks, mate. That was great.
Thank you.
Good cases. And Behnaz, have you got a little morsel prepared for us as well?
Yes, I have a bit of change of subject, but yes. So I was, as you know, Michael, I was initially going to talk about peds abdominal ultrasound more in pediatrics, and then I thought Salman is going to take plenty of time, so I couldn't squeeze it in 20 minutes. So I'm going to leave that for another session. And we thought that Dom spoke about some peds abdominal cases previously, so we're going to leave it for February or January. But I'm going to now talk about use of ultrasound in airway assessment, and I think Briefly, I'm going to talk about cellulitis and abscess. So yeah, I'm ready to share my screen when you're ready.
Behnaz, you're the host now, so I think you can.
Okay. All right.
Yeah, we do have an anaesthetist in the group as well, Behnaz, by the way, but no pressure. He's very
Oh my
friendly.
God. Okay.
Yeah, feel free to chip in, Justin, if you have any
No, where's no
pearls you want to
pressure,
share.
no pressure.
Just looking to see how I share my screen. Am I host?
Yes, Behnaz, you're the host.
I'm the host. Okay. One sec. Yes.
Keep talking.
Can you see my screen?
Yes.
Okay, brilliant. So, as I mentioned, I'm just going to talk about airway management. As you know, as emergency physicians, airway management is one of our essential skills, and difficult airways have got significant potential to go wrong and complications to happen. Traditionally, there are some physical examination maneuvers that we can use to assess and manage difficult airways. And there is increasing use of point-of-care ultrasound in assessment of airways. So I'm going to start with a case. A 25-year-old male has been involved in a car accident, pedestrian versus car. He's had a GCS of 6 at the scene, and the pre-hospital team have performed RSI, and unfortunately, he's in cardiac arrest. And if you are the trauma team leader for this patient, you know that two of the major dilemmas is when the patient comes in, they've had an RSI, they're intubated. One of the main ones is to see if the tube is in trachea, in the right place, and also if the tube is in the right depth and appropriate depth. There are some conventional methods that we have been using to confirm the ET tube position. One of them is direct visualization, which if the patient has been tubed previous to coming to hospital or pre-hospitally, that wouldn't apply. Auscultation and chest rise, as you know, in a busy resuscitation room is not a very productive assessment tool. Capnography is, calorimetric capnography is one that pre-hospitally is used a lot, but by the time they get to hospital, to our setting, they don't have much use. Chest X-ray should never be used in assessing whether the tube is in trachea or is in esophagus for obvious reasons. And of course, one of the most useful tools that we heavily rely on is Untitled CO2 monitoring. However, Untitled CO2 monitoring is only 60 to 68% sensitive in identifying endotracheal tube position in patients who are in cardiac arrest or patients with massive PE or patients in severe pulmonary edema. They're also less reliable in patients who have been previously bag valve masked, patients who have ingested carbonated beverage prior to what happened to them. And like I mentioned, in cases where there's paucity of carbon dioxide production, such as cardiac arrest, massive PE, and significant pulmonary edema. And also you have to give the patient at least 5 good breaths before you produce the entitled CO2 waveform. And if the tube is in esophagus, that will result in distension of the stomach, could result in vomiting, aspiration, etc. And it will take time before you can see the waveform, therefore. There's plenty of evidence out there now for the use of ultrasound in both adult and pediatric airway assessment. So you name it, it's been looked at. So there are studies on assessing airway using point-of-care ultrasound, identifying difficult airway, predicting pediatric ET tube size, confirming endotracheal tube position and depth, There's also studies looking at identifying cricothyroid membrane for emergency access and identifying the tracheal ring for ultrasound-guided tracheostomy, as well as diagnosing laryngeal trauma. For the purposes of this discussion, I'm just going to focus on confirming endotracheal tube intubation using point-of-care ultrasound. And just briefly, I'm going to talk about the ET tube depth as well. So there's plenty of evidence, and the port sensitivity and specificity is between 96 to 98% for use of point-of-care ultrasound in identifying esophageal versus endotracheal tube intubation. It only takes 9 seconds, so it doesn't take long at all. The point-of-care ultrasound is noise independent, so no matter how many people you have in your resource bay, if you have a good operator, they can do it. And it's not circulation dependent, therefore it doesn't have the caveats that Untitled CO2 monitoring has. There are some cons as well. Obviously, you have to have a provider, you have to have a practitioner that is competent to do it, and you have to have an ultrasound machine in hand as well. So you can confirm the intubation either directly or indirectly. Directly is by looking directly at the endotracheal tube during or after intubation. So the examination could be done dynamically or statically. Dynamically is when you have someone intubating the patient and you have an ultrasound practitioner who is just having the probe on the skin and just visualizing the intubation. And you can have it statically where it can be done retrospective. So after the intubation has been done, so the intubation has been done using the point-of-care ultrasound, just confirm the position of the tube. And then indirectly as well, by looking at long sliding and diaphragmatic movement on both sides. If you can see long sliding in the anterior chest in an intubated patient, you can conclude that the tube must be in trachea. So out of the emergency intubations that we do, about 3.3% are esophageal. And as you know, unless promptly recognized and prompt interventions are done, they can be associated with significant morbidity and mortality. Traditionally, we used to use direct visualization of ET tube going through the cords. But of course, if the patient has been intubated prior to coming to hospital, that's not possible unless you take the tube out and re-intubate. Using breath sounds, as we discussed earlier, it's not really very reliable, and the Untitled tube misting has been used as well. So the evidence for use of point-of-care ultrasound in ET tube position is quite strong. So pooled sensitivity and specificity is in high 90s in both adult and pediatric group. Specificity in pediatric group is about 100%. This is also consistent finding regardless of the tube size and also regardless of the transducer. We're going to talk about technique in a second and tell you about the transducer that we should be using. And it's a relatively easy skill to learn as well. So it's quite promising. So when do we use it? Like I said, in circumstances where we think Untitled CO2 could be unreliable, if the patient, for example, is in cardiac arrest or they have massive PE or for whatever reason they have poor pulmonary blood flow. If because of the emergency situation or like high grades of malempathy, you have to do blind intubation. If the patient arrives intubated, or if you decide that you're not sure if the probe is in the right tube or not, before taking it out, it's worth checking with PoCUS to avoid reintubation and removing the tube. So in terms of the technique, these are the kind of probes that we have in hand. This is, as you know, is the linear probe. It's a high frequency probe. We frequently use this probe for the purpose of airway assessment. This is hockey stick. This is, again, high frequency probe. It can be used in younger children and neonates. Some practitioners use the curvilinear probe. They think it just gives a wider footprint. And this is the phased array probe, and this is the probe that we shouldn't be using really. So this is, in terms of technique, this is where you put the probe. So you have the patient in supine position. The linear probe is the one that we commonly use. You put some gel. Remember, we're putting the probe on the suprasternal notch. And remember, there's a concavity in some patients that needs to be filled up with gel. If you have air in between the probe and skin, you won't see much at all. And this is roughly the view that you would have. So you have this kind of curvilinear aeromucosal interface with some ring down artifact and some shadowing. This is trachea. On the either side, you have this hypoechoic homogeneous tissue, which is the thyroid lobes, and these round and echoic circular tubular structures are carotid arteries. And this is esophagus sticking out. So unlike what we were told in anatomy, esophagus often, especially in a supine patient, is not directly behind the trachea. It's probably the pressure of cricoid, usually, or the pressure of the probe when you're scanning. Usually the esophagus slides to either right or left, usually left of the trachea. So esophagus is usually seen as a tubular structure with a hypoechoic, sort of hyperechoic wall and a hypoechoic center that sticks out from the side of the trachea. So again, like I mentioned, you've got the probe in the suprasternal notch, transverse plane. Make sure there's contact with skin. If there's a concavity in the suprasternal notch, that needs to be filled up with gel. And we're looking in the space below cricoid cartilage and suprasternal notch, so that gap there. And this is roughly what you would see normally. So you've got thyroid tissue, this homogeneous hypoechoic shadow is the thyroid lobe. This semicircular shadow with a kind of hypoechoic line is the cartilage of the trachea. And this ring down artifact, kind of reverberation artifact with some shadowing behind it, is the trachea. And typically, this is how esophagus would look like. So it's usually collapsed. It's almost always collapsed, so it doesn't contain air. So you see it as a hypoechoic shadow sticking out from either right or left of the trachea. Now, if you intubate the trachea, you would only see one lumen. In the event that the tube slides into the esophagus, then you would have two kind of semicircular hypoechoic shadows. And this is called double track sign. So this is what you don't want to see. So here, remember, you've got this one shadowing behind the trachea, and because esophagus is normally not air-filled, it's collapsed, you would not see any shadowing behind it. But once you put the tube in the esophagus, then you would have two shadowing, and that's called double track sign, and that's what you do not want to see. So again, here you can see suprasternal notch. You've got the high frequency linear probe. You apply your gel, and you can see trachea, the vessel. So this is internal jugular, this is carotid artery, and this kind of hypoechoic shadow here is the esophagus. And as you can see, you have one tube, you would only see one sort of shadowing. If you see two shadowing, then you should be suspecting that the tube has a slit into the esophagus. So this is when the tube would be in trachea again. It's called bullet sign. So again, you can see this semicircular curvilinear aspect of the anterior trachea with some ring down artifact and some shadowing. This is esophagus, and as you can see, there is no shadowing behind it because there's no air in it, and this we call bullet sign. Again, double track sign. Once the tube is in esophagus, you would see two kind of shadowing, two tubular structures with shadowing. You can also move the tube. So if you put your color box on the area of interest, so here would be trachea or trachea esophagus, if you move the tube and you've got the color box in it, you will see some color rays. If the tube is in esophagus, you'll see it outside trachea, and then you know that the tube is not in the right place. Now, there's also some indirect signs that you could check to make sure that the tube is in trachea, and that's by checking lung sliding on the anterior chest wall. So the way you do it in a supine patient, second or third intercostal space on both sides, you would check for pleural sliding. A sliding has got 90 to 100% sensitivity, and a bit less specific in confirming the tube position. So, pitfall, what can you see in this image? Just unmute yourself and just say something.
Is that a nasogastric tube?
Exactly. So here you can see the trachea in the center, the carotid and internal jugular vessel on either side, and this is NG tube. So again, you can see the tubular structure with a bit of shadowing because this is air-filled, and always look at the patient. So if you can see an NG tube, that's an NG tube in esophagus, you know. And of course, this is a bigger patient. Of course, in a young patient, you would look at the patient, each tube could be this size, but again, you know, you put it in the clinical context. If you can see the patient has got NG tube, you look at the neck and you sit in the esophagus, and that confirms the NG tube in the right tract. So I'm just going to briefly also talk about the depth of endotracheal tube. So ultrasound has been used in assessing whether the tube is deep enough. So as you know, if the tube is pushed too far back in, it can cause main stem intubation, which accounts for almost 8% of all intubation. It's associated with significant barotrauma of the intubated lung and atelectasis of the contralateral lung, and in some patients, it can cause respiratory failure. If it's further out, if it's not in enough, of course, it can become dislodged, which can be a major issue both in adults and particularly in neonates and younger children. So again, traditionally, we have been using auscultating both lung fills to you know, see if there is equal air entry and bilaterally, but that's very crude. That's not a very reliable way of confirming. So it is believed that if the ET tube cuff is at the level of sternal notch or suprasternal notch, that corresponds to the tip of the tube to be about 2 centimeters above the carina, and therefore the right depth. So to confirm the tube position, we can use lung sliding. So if you can see lung sliding on both sides, then the tube is in the right position. We can also use tracheal dilatation and inflating the cuff with fluid, which I'm going to talk about now. So this is a study that was done, I think, 2016 by Ram Singh. He's an anesthetist, and essentially this is a study, they looked at a dilatation of the trachea at the suprasternal notch. So the kind of it's about a couple of centimeters between the cricoid cartilage and suprasternal notch. They monitored the area when the tube was inflated, and they concluded that tracheal dilatation, if you can see it in the suprasternal notch, it's got sensitivity of 93% and specificity of 96% in confirming the correct tube depth. So seeing the dilatation means that your cuff is sitting just above the suprasternal notch, and that corresponds to the tip of the tube being about 2 centimeters away from the carina or above the carina. Whereas auscultation is only 66% sensitive and less than 60% specific. This study was done by Mark Tesoro. He's a PEM physician, so this was a pediatric study, and they basically inflated the balloon with normal saline. And if they could see the tube, the balloon actually becoming more obvious, then they concluded that the tube is in the right position. So they're keeping the probe on suprasternal notch, and they are inflating the balloon with fluid, so sterile water and normal saline. And once the cuff is filled with fluid, it becomes more visible, and you may also see some post-acoustic enhancement, as you can see here, and that confirms the satisfactory position of the tube. And of course, some people get anxious about putting fluid in the cuff instead of air. So what they suggest is that you inflate the balloon with fluid, normal saline or sterile water, confirm the tube position is in the right place, fix the tube, and then replace the water with air. So in summary, ultrasound, there's increasing evidence to support use of ultrasound as an important non-invasive adjunct for verifying the ET tube position, particularly in emergent intubations. There is no single confirmatory method which is perfect and entirely reliable, but combining different techniques kind of increases the overall sensitivity and specificity. And it is important to remember that entitled CO2 will heavily rely on it, but it comes with significant caveats in patients in cardiac arrest or massive PE, or patients with compromised pulmonary blood flow. And most of these studies, there are quite a few studies in pediatric age group, and it's a reliable technique in that as well. So I think I can take any questions.
Thanks so much, Behnaz. That was great. Really interesting.
If there's no questions, then we
If
I may, I have one question. Justin here. I'm one of the anesthesiologists here in Amsterdam. I was wondering, so thank you so much for your presentation, first of all, but how do you practically use ultrasound, airway ultrasound in a cardiac arrest case? Because most of the time, for example, when I'm involved in a cardiac arrest case and we have ultrasound available, I usually use it just for the ABC. So basically for lung, hearts, abdominal, vein ultrasound, and not so much for airway ultrasound, to be honest. And usually I use all my resources just to do cardiac ultrasound in these type of cases. How do you work it in practically?
So, so the way that we do it, or it's done, is we allocate one person for kind of doing all the ultrasound examination. That's the way I can suggest that should be done. So once the patient arrives, if the chest compressions are happening, and obviously the anesthetist would be busy confirming the tube position, then I guess that's the window where the ultrasound practitioner can put the probe on the neck suprasternal notch and confirm the tube position. Does that answer your question?
Yeah, sure. Thank you. So do you use it practically that way too?
So I think in our setting, it all depends on availability. So you have to have a practitioner that is competent to do it. And we in our department don't always have that. Of course, we've got a few registrars who are really good with ultrasound. So if one of them is around, you can do it. But as consultants, we often end up being the team leader, and the team leader can't do it unless I'm a second consultant around, you know. So like I said, it does have its own cons as well. So you have to have the operator that is competent to do it. And that practitioner doesn't have to be the team leader. So you have to have person allocated to the scan, so they can do fast, they can do echo, they can use ultrasound for different applications. But you have to have the person. It's operator dependent. Depends on the availability.
Yeah, absolutely. Thank you for your answer.
It seems like Behnaz, like the technique is fairly straightforward and the evidence is there to support it. But probably logistics is one of the big challenges. Like, like in an arrest, you can make a good argument for it because the issues with end-tidal CO2. But what about in other RSI cases in ED, non-arrest cases? Like in those cases, I think maybe someone needs to mute themselves. In those cases, is there any sort of friction between, like, if anesthetics have put in a tube and then you guys want to do an airway ultrasound to confirm it? Does that ever create any tension? Like, do you find your anesthetic team are on board with the idea of that, or is it like?
I think they are. I think our major obstacle is staffing, is the operator that is confident to do it, and so I think that's our major obstacle. Yeah, I think that's the issue with most of PoCUS applications. I don't know how it is in your department. Our department is huge, obviously, but comparatively, we don't have that many ultrasound competent staff.
Yeah.
I think that's one of the major obstacles in our practice, but I don't think there would be an issue with anesthetists.
Yeah. Okay. Cool.
Yeah. As if I can chip in on this discussion, I completely agree that there shouldn't be any ego issues when confirming a tube position placed by whoever. I've used airway ultrasound before, also in arrest cases, but mostly in the setting of if I want to know if the tube is in the right position, I do direct laryngoscopy or video laryngoscopy. In my experience, it's faster than setting up the ultrasound and getting everyone on board to use the ultrasound, or having people look with me to indirectly, if you don't see, if you see empty esophagus, still the tube can be above the vocal cords, positioned in the mouth. So it doesn't mean so much in my book. So I do a direct laryngoscopy to visualize the tube passed through the cords as a good confirmation, and all the other indirect confirmations like bilateral chest, bilateral pleural sliding and everything, those are not 100% for tube position, more for ventilation of the lungs. So it's not a proof. So usually I just use the direct laryngoscopy or video laryngoscopy so that everyone can see visually it's in the right position. And if there is doubt, if you have a very hard airway or a blood-filled airway, vomit-filled airway, and it's very hard to visualize the tube passed through the cords, then I would use ultrasound to exclude it from the esophagus if there is no end-tidal CO2. But I can't really recall any case where we have these doubts. Thus far.
Yeah, I totally understand that, and I think it's important to remember that a lot of these evidences that we have, they come from North America, and they typically don't have anesthetists to intubate their patients in the emergency department. Emergency physicians do it. So we have the luxury of having anesthetists coming down and do our intubation most of the time, not always, but in the majority of cases. But a lot of these studies, they come from US. And in a couple of the studies, they also mentioned that fiber-optic intubation is not necessarily always available, or even entitled CO2 is not always available to some of their emergency departments. So I think that's why they they probably are looking to train their emergency physicians to be capable of doing this in case they don't have fiber optic intubation tools, or if they don't have entitled CO2 monitoring. But the majority of the emergency physicians, they perhaps they do more PoCUS than we do here in the UK. So I think it's important that their settings is a bit different from ours.
Yeah, absolutely. I completely agree. And, you know, if anything, this is a beautiful technique to exclude a esophageal intubation. And also, if anything, it makes you more acquainted with the neck anatomy. And as you've shown photos of pictures before of nasogastric tubes through the esophagus, it's also a beautiful way of placing a nasogastric tube in the right position. You know, if you see it on the ultrasound, then you know for sure it's in the right position. It never hurts.
Absolutely.
And again, you know, if you don't have the end-tidal CO2, and if there's any doubt, then of course use it. It's a very good tool in your toolbox. So I completely agree with you.
I totally agree. I think it's just a matter of having another tool in your toolbox, so that if you don't have end-tidal monitoring for whatever reason, or if you think it's not going to work, or if you don't have fiber optics, it's just going to help you. It's just having another tool, really. It's not meant to replace any of the things that we're doing, but it's just, you know, it just helps you.
Yep, absolutely. Well, thanks so much, Behnaz and Salman, for your amazing presentations. That was really fantastic. I'll put the recording up on the Slack group, and hopefully everyone here knows about the Slack group. If not, check it out. There's lots of great resources up there, as well as these monthly teaching sessions. So yeah, thanks again to everyone for joining. And see you next month. Some echo with Anna and Kian next month in December. I'll post the link on the Slack shortly.
Looking forward to it.
Thank you, guys.
I did have a few slides on soft tissue, but I think I'm going to leave it maybe for another session.
Yeah, maybe we leave that till next time.
Yeah, it's only a few slides. That's absolutely fine. We can leave it for another day.
Yeah, sorry, I forgot about that. Apologies. Yeah, let's do that next time.
Yeah.
Cool.
Yeah, we'll do it another time.
Great.
Great. Thank you so much, Michael.
Thanks, everyone.
Thanks for organizing this.
Pleasure.
Thanks very much, guys.
Thanks, guys.
Thanks, guys. See you later.
Bye.